My second case is a 63-year-old lady with diabetes, hypertension, and gout. She was also diagnosed with a diffuse large B-cell lymphoma, stage 2, and she was treated with the rituximab and SHOP, which is cyclophosphamide, adriamycin, vincristine, and prednisolone. She was admitted in January early this year for the third cycle of chemotherapy when she had symptoms of rhinosinusitis as well. So her hematologist has prescribed her an amoxicillin clavulanic acid plus Actifed, and then still give her the third cycle of chemotherapy. A couple of weeks later, she was readmitted for a high fever, cough, persistent rhinosinusitis symptoms, but at that time, she doesn't really have any lower respiratory tract symptoms in terms of short of breath or desaturation yet. Her X-ray, when looked retrospectively, there might already show some increased interstitial infiltration without clinical. Her saturation at that time was like 95% room air. Her white blood cell count, she had a leukopenia. Her sputum gram stain shows on flora, but it's probably inadequate. Her meds taken, she already took Bactrim, fluconazole, and prophylactic cyclovir at that time. She still has some cloudy of her sinuses. So she was changed her antibiotics to moxifloxacin just to treat sinusitis. 2 days later, she get worse, more short of breath, higher fevers, desaturation to 86, 87 something percent on room air. So her white count is already up by the neurogen. So what's going on right now? Diffuse interstitial infiltrates, increased LDH more than her baseline, and desaturation, some form of diffusion defects. The CAT scan also correlates with the ground-glass infiltration. If you have to think of some infectious pathogens in here, it must be something like a PCP, which is unlikely. She's already on Bactrim. Could be viral infection. Anyhow, whatsoever. Let's do this. Embrick first. Bactrim, Tamiflu, Bactrim to the treatment dose, Tamiflu, and dexamethasone. And then, as we know, that the yield of the bronchoscopy in this type of patient is very high. So, and not to change the profile of the infiltrates. So let's do this. This is the day when she get Abelox. This is the day when she get Bactrim, Tamiflu, and Dexan, and I did the bronchoscopy right the next day. And this is what the transvital bronchial biopsy results show. It showed diffuse interstitial infiltrates with mononuclear cells, and there's some organizing area of the fibrin exudates. So what is the diagnosis? It's a rituximab-induced interstitial pneumonitis and organizing pneumonia. The bronchoscopy was done early enough, thus a negative BAL study was able to help exclude some infectious etiologies. For example, the PCP, the fungi, or the higher bacteria. So, most of the pulmonary complication in the rituximab-induced interstitial pneumonitis occurred after the first few cycles, just like some other case reports. See that? Very similar to our case. Rituximab-induced interstitial lung disease. This is very interesting, the previous slides. If you can see, they also can present as a rhinitis or sinusitis symptoms. So, what I did is that there's revealed no infectious pathogens. Let's stop all the antibiotics, switch the Bactrim back to the prophylactic dose, and give an extended course of the prednisolone. And she did well. She's still alive. Both of the patients still alive with a happy lung. I don't know about the lymphoma though. Her serum procalcitonin at that time was just only 0.068. That makes me feel more comfortable to stop the antibiotics. H1N1 PCR in this case was negative. Her statin growth 4 days later to 96%. So the critical points that I would like to make here is that first, to recognize the underlying types of immunodeficiency and potential opportunistic infections. Patterns of pulmonary infiltrates, because you guys already know that the upper lobe predominates, peripheral infiltrates. It's really compatible with the eosinophilic pneumonia. Temporal relationship with the treatments, the chemotherapy cycle, the antibiotics. The surge in immunocompromised hosts may not always be due to sepsis or solely due to sepsis, due to infection. For example, in this case, in the first case was related to the primary disease, and the second case was related to the treatment. And well, let's consider some early invasive diagnostic procedures, for example, bronchoscopy, can be very helpful. So I would like to end my talk here. Thank you for your attention.